Hello, everyone.
Hello,
Hello.
hello everyone.
Hello.
Hello, everyone. I think we're still waiting for a few more people to arrive. I don't think Dr. Lee is here yet.
Hello,
Hello, Dr. Lee. How are you doing?
I'm good. Thank you very much for giving me the opportunity.
Hmm. Yeah, hello, Dr. Waiting for Dr. Alo. I gave him the link. I haven't seen him yet. But normally we wait until about 5 minutes after to get started. So,
Okay,
do you need access to share your screen or anything?
okay, I will.
Let me check and get you ready. All right, you should be ready to go. So we'll wait a few more minutes for anyone else who's coming, and then we'll get started.
Okay.
Mm. Yeah. Hello, everybody. Good afternoon. Can you hear me okay?
Good afternoon. Yes, we can.
Good
Good
Okay,
afternoon.
afternoon.
great, great. We're so very, very pleased today to have one of our speakers is Tien Van. Oh, where are you? Oh, there you are.
Yeah,
Okay,
yeah, I'm here. Yeah.
see you. So pleased to have one of our speakers today return from the College of Pharmacy, who has been doing outstanding work using artificial intelligence, well, in particular, machine learning and deep learning in cancer, in cancer recognition. And, this is one of the significant uh, uh, advantages of artificial intelligence is the ability of AI to predict and then prescript. And this is really amazing stuff. And as IBM has said 2 years ago, this is what's going to help us cure cancer. And I firmly believe it because this ability to predict what a tissue is going to do is an amazing outcome. So, with no other further ado, Tien, can you go ahead and introduce yourself and your role in the College of Pharmacy and the title of your talk, and give us a little bit of your background, okay?
Okay. Hello, everyone. Thank you very much for giving me this opportunity to make a presentation about the AF and between the relation between cancer and atrial fibrillation. We know that just as Dr. Ando said, that it's very important in our field. And in today's presentation, I have the opportunity to use the UK Biobank and it give a bigger picture. And I think it's the time for us to make a presentation about that, and we can know more about that. Let me share my screen.
Okay, I see it. Tien Van,
Yeah,
does
yeah.
everybody see the screen? Okay,
Hello,
go ahead.
everyone. Yeah, thank you very much for giving me the opportunity to make this presentation. In the research, I will use the machine learning and deep learning approach to explore the relationship between cancer and atrial fibrillation. In this research, I'm trying to explore for patients within atrial fibrillation and what factors may have them have cancer in the future. And in this research, it conducted by me and Dr. Dominic from the University of Iowa and Dr. Aprilia from the University of Buffalo. And we know that before we started, before we explore our research, we shall know that there's a complex relationship between AF and cancer. We know that there's a complex directional relation between them. In this research, I want to explore for patients after they have the IF diagnosis, want to whether they have the cancer in the future. And we know that even have early risk prediction, it could help us to monitor the patients. It can help us to improve the outcomes. For the UK Biobank, we currently have more than 500,000 participants. And in this, for these all participants, I can divide them into 6 categorical patients. Patients, they don't have disease, and class 1, they only have cancer, and class 2, they only have cancer before AF. So class 3, they only have AF. Class 4, they have AF before they have cancer. In this research, this is our target participation. And in this research, we have more than 32,000 participants in this research. And we have a class 5, we have AF and cancer in the same time. Do the research. But here, in this research, I want to employ this class 4. What factors could help us to predict patients, AF patients, whether they have the cancer in the future?
So, Tian, can I ask a question? Tian?
Yes. Yes.
No, yeah, excellent. My question is this: is this for cancers in general, or could we narrow it down to more specific types of cancer? For example, say leukemias or genetic type cancer. I mean, what could we can we be more granular, or is this in general? I'm trying to.
Yeah. Thank you for asking. In this research, for this more than 5,000 participants, we only have the in this research we only report the general cancer.
Okay. Yeah, I'm sure you'll get more. You'll get
Yeah.
yeah.
In that set, we have five domains information about the patients. First one is about the diagnosis. We know for the diagnosis, we have ICT-10, we have diagnosis 0, diagnosis 1, 2, 3. Here we have the broad disease chapters to detailed subcategories. That information we have about the patient diagnosis. And we also have the medications like the from drug classes to specific medications. Okay, medication 1, 2, 3, 4. We mean that because we care about even the patients take medications, and then what kind of medications can may increase the risk for the patient to have cancer in the future. And we also have the procedural information about the patients. We know that when the patients have the AF, they may have all kinds of, after they have AF, they may have all kinds of procedures. But we should to know what kind of procedures may increase the risk for them to have cancer in the future. And the first one, we have the clinical measurements, like the lab tests, vital signs, and other information like age, sex, race, and GP income information, something like that. And for the missing data in this research, we use the imputed GPU accelerated and GPM this math method to impute the missing menus. And here, we know that for the machine learning and deep learning research, it's very important for us to do the feature selection. Especially for this research, we have more than And we say we have more than 300,000 observations, and we have more than 4,000 features. There's a huge amount of features. So it's very important for us to reduce the dimensions of the features, and it could help us to make accurate information. Accurate means estimation for the impact of the features. And in research, we keep these three stages to do the feature selection. First one, the filter measures to remove the redundancy. And the second stage two, we use the embedded measures. We can learn the importance. And the third one, we use the random measures to validate the performance. There's a three stages we use to do the feature selection. And here, one knows that even we do that, it's not enough for us to scientifically reduce the dimensions of the features. For this purpose, we use the statistical validation and the clinical relevance. This method is often used in the nature journals. So I follow that method to do this. And for this purpose, we use the univariate regression analysis. I also use the multiple testing correction method. And for this purpose, we consider statistical significance and meaningful effect size. And through this way, finally, we simplified the amount of the features. We total have 29 validation predictors. These 29 predictors, they are statistical robustness and they are clinical significance. So they're very important for our research. And we can see here, after we do the feature selection, we can see that we have the predictive biological odds ratios. We have this, from this one, we have Asian, Black, and now we have the Med4. That's the kind of C1EB. That's the kind of the code of the medication. We have all this information, and then we have totally we have 29 features to for the selected features of our research. And then we also see that you can see we have another plot help us to display the risk for the different types of features. Here we can see we have the for this color we have the medication. We can see for the patients for the top 29 features, we know that medications occupy the priority, the majority of the features in affecting the patients who have the cancer in the future. And we also have other 1, 2, 3, 4. We have 4 features. This kind of diagnosis we will to the whether we have cancer in the future. And under this, we have other demographic information. You can see the race, Asian, and race Black. We have the gender information, and then we also have other information about the procedure, 2 items related to procedures. And then we have the smoking status also affect whether patient have the cancer in the future. After that, and then because all this is a class in balance, we use the smooth method to balance the observations. In this research, we use machine learning methods, 6 machine learning methods, with 4 deep learning methods. Machine learning methods like XGBoost, like GPM, CalBoost, Reinforced, electoral trees, relative regression. For the deep learning methods, we have MLP, tablet, transformer, and Synth. We have this deep learning and machine learning methods. And to make our research more robust, and we do not use the one single reader given seed with the 10 random seeds and plot times five-fold correlation. And then we use the average information to get the results of the each model. Here, we can see to now we need to review the model performance. To overview the model performance, we use this matrix AUC, PIUC, accuracy, precision, recall, specificity, F1, balanced accuracy, MCC, with this matrix. And then here I will show you the data class and to show the training performance combined with the testing performance across this each matrix. And we can see that, let me see the, we can see that here, this is the performance for these matrix. We can see that this is the traditional motioning model, traditional machine better than the deep learning model. And we can see here, also part of the AUC curve analysis. And we can see here, we know that this is the AUC curve. And we can see that from this plot, we can see that the if we consider the training part, the deep learning model are better than the traditional machine model. But we see that even we consider the testing data set, the machine learning model is better than the deep learning model. And then we see we also have the information about the confusion matrix inside. And then we have this information about the information about this line confusion matrix. And then we continue that traditional model is better. Model is better than the deep learning model, especially for the arbitrary trees and logistic regression model are better than other models. And then we use the precision recall curve analysis because I mentioned that at the beginning our target outcome variable are imbalanced, so we need to use the precision recall curve analysis to check the information. And then we can after we see that we can see and we see that the traditional is better than the deep learning model. The information about the precision recall curves. And then now we have these models. We need to determine which model is the best one. In the part of research, we may only consider one metric or two metrics to determine which model is the best one. But here we use a Friedman test and Nemini post hoc test. And this method can help us together determine what model is the best one. We can see here using the information about the hidden map, information about these models, and we also have this information about the Friedman test ranking and the top 6 ranking. And then we see this plot, we can see for this method, for here we need to know that for this one, random forest is the lowest score, and lowest is better, and average rank is for the random forest readable is the best one. And then we also consider top 6 score, and we can see the random forest is better. And then we consider these two information together. We know the random forest is the better one, is the best one, is the best model for our analysis. And after that, after we random forest is the best model, and then we use the shape summary shape analysis to help us to analysis what feature and what features are more important than the other features in predicting the outcome variable. And in when we use shape values, we continue the 10 reinforced models on test set. And we can see that here we have the shape summary information about these features. We can see that among these 29 features, we know this is the metaphor, and then this is the gender. Gender is important. And then we have another one, metaphor B, another medication. We have for the first one, there is the procedure, and for the fifth one, the medication, and for the sixth, for the seven features are the diagnosis. The two features can help us to predict whether the patient have the cancer in the future. And here we can see after we notice the basic information about the direction of the features, and then we have the information about here we have more information about the feature importance and the progressive information about the features. We can see that among these 29 features, the feature 1, metaphor, this is the code B01A. This feature has an important impact among the 29 features. And the second one is the sex, and the third one is metaphor B, and the third one is the procedure, and the fifth one is the medication. And next one, number 2, is the diagnosis. We can see from this figure, we can see that these 7 features can help us to predict can let us know the majority impact of these features on patients, whether they have the cancer in the future. But even we consider another feature, you can see here is metaphor C01BC. This feature can give us the largest accuracy progressive AUC score. But we can see that from this plot, we can know that even for the simplicity consideration, these same features can help us to predict whether a patient will have a cancer in the future. And then we see now we have more information because we wanted to know here we have the statistical and clinical significance landscape. And then this map can provide more information. Here you can see for this area, these features are only clinically significant. For features in this area are those features and statistical significance. For this area, they are both statistical and clinical significance. So we can see that these features could help us to predict the likelihood for the patients to have cancer or not in the future. And now with this information, and we can do the single feature dependence analysis. And here we can see that we report this information. We report this 11 features associated by the map we made here, and to report the how the single feature affect outcome variable. For example, for the gender, we can see this is 0 means the female, and this one means the male. That's the information. If the patient is a male, no likelihood to have the cancer in the future. And I want to give you another information about the Asian. You can see for this, even we talk about the Asian, the Asian people may have a higher likelihood to have the cancer in the future. We can talk about this medication. About this medication, we can see this medication B0A can help to reduce the likelihood for the patients to have the cancer in the future. And then we also have the information about the procedures. You can see these procedures can help us to reduce the likelihood to have the cancer in the future. And I want to here, so the information tells us how whether a patient to have the cancer in the future. And we also know that in the real world, the patients are not only affected by the single feature, they are also affected by the molecular features. So we need to consider the impact of the interaction between two features and how the interaction of two features affect the outcome variable. And in this plot, we report the top 12 feature interaction, how the top feature interaction affects the outcome variable. Here you can see the value for the impact of these two feature interactions is 0.321. Here we can see this. Here we can see this. For the metaphor, and for the interaction between metaphor and the metaphor C10, these two features can increase the likelihood of the patient to have a cancer in the future. And we also have this for the second intervention of two features, one medication for C0, C10, AA, and the second one is the medication C0, C07, AB. This is the information about how the feature affects the likelihood of the patient to have cancer. And we also want to tell about the, here is the information about the gender, information about the medication. So we know from here, we know that for different gender, even the take medications, they will have different results. Here we can see that for the male, even they take the medication, they will have a higher likelihood to have the cancer in the future. So with the information about the patients have the cancer in the future a lot. And we will also some other information here. I want to show you because we have so many patients here, and we have the opportunity to cluster the patients in different way. Here I want to show you in my Google file to show you the information about the here. I want to show you the information about here we cluster the patient. You can see here we have the patient. We have so many patients, and we cluster this, patients into 11 clusters, and we can see patients have a high risk, and the second level, and the third level, fourth level, and the middle level will have the lowest risk. And for the highest risk patients, we have 829 patients are in high risk. And here I take one example for the high risk. For these high risk patients, we can see we have information here with the high risk representative for the patients. Here, that means that zero. That means if these patients doesn't take the medication, maybe 101A, and it will increase likelihood for them to have the cancer in the future. For this medication too, for this medication 4B, this medication, if the patient doesn't take the medication, it will increase the medication, it will increase the cancer for them to in the future. Similarly, we have information on the procedure, medication form, and the diagnosis 3A, and this information. For this real one, we can have the information about whether patients to have the cancer in the future. And I want to give you another example about the low risk relative. Here we can see that even for these moderate patients, even for these patients have no risk likelihood to have the cancer in the future. But for these patients, they have this characteristics, it will increase them to have the cancer in the future. I also have information about, here we have the 11 features, we have 11 characters. We want to explore, to compare these 11 features together to get to know how these different characters have different likelihood for them to have the cancer in the future. So that information about how the cancer of the patient in the future. We can see this, the total features for the patients. So that's all. I want to give you some conclusion of the research. From literature that we know that traditionally the machine learning model is better than the deep learning model in this research. And in the second point, I want to report that what patients may have a high risk to have the cancer in the future. Specifically, if the patients have the anti-go accumulation optimization, like the genotyping, DOSS, or intensive INR monitoring, and these people may have a high likelihood to have the cancer in the future, and then we need to consider this intervention. And also for the class H patients, they need to consider mandatory avoidance and genital protection protocols. This is information. And also for the Asian patients, we need to appropriate risk communication and plus the monitor their health conditions. This patient may have a high likelihood to have cancer in the future. That's all. Dr. Anna?
Dr. Alo, that's can you hear us?
Oh, I'm sorry. I was on mute. I'm sorry. Yeah, I said I do have a couple questions, but I'm wondering if let's hear from the participants. Questions.
Mm,
Go ahead, please.
okay.
Are there questions? Please, either you could put it in the chat or raise your hand, and we can unmute yourself and ask.
Hello, Dr. Lee. How are you?
Yes, thank you, Dr. Williams.
Thank you for that presentation. So I have a quick question. I noticed class 4 looks at AF patients before cancer. So I'm wondering what made you focus on the AF patients? And so my question is, what percentage of AF patients get cancer?
What are the F patients get cancer? We need to actually we have data information. Let me see. I may give you here. We know that we have the 22,000 participants, and we have the information. Let me see. I have the information because the let me see. Show you the information about the. Right now, I may not give you the specific information. I have the information. Let me have a check the information about type. Let me see. Wait a minute. Let me check the plot. I may get the information.
Oh,
Yeah. Sorry, right now I cannot give you the information. I'm giving information after this presentation.
Okay,
Thank you for your question.
thank you.
yeah, yeah, Tian. Carrying on with that question, that's a very good question that was just raised, and I'm wondering, following through on that,
Mhm.
what level of discrimination can you make amongst the various types of cancers? In other words, the tools that you're using, can you discriminate further amongst the various the different types of cancer? How wouldn't that make a uh, a more difference? Wouldn't it be? Would we not be able to get more predictive information from that? To follow what
Uh,
I'm after.
yeah, for the specific cancer, right? Yeah, I think that we right now is the initial results we just do the research, and I have on this project for several months, and right now this research right now the research is we have three research. First, first one, we have the want to explore for for F patients want to promote whether they have a cancer in the future. This one research project. Also that some patients may have cancer. Some cancer patients they may have AF in the future. So we want to explore for these cancer patients, what factor can help us to predict whether they have the AF in the future. So that's the second research project. And for the third one research project, you know that we have here, we have more than 500,000 patients. We know that here we have six types of patients, but we want to know what factors can help us to classify them into six types of patients. I mean that how do we know whether patients we don't have any disease in the future? They only have cancer in the future, or they have the cancer before the F. This is a second research project. And for a research question, I think that we're very valuable. Other we do this, we shall consider more specific information. Like for the specific cancer, whether breast cancer or whatever cancer, something like that. I think very good question. And because we have this big data set, we can do more research on that.
Mm.
Okay, so let me add, hi everyone. Let me add, since I've been working with Tia Feng on this atrial fibrillation and to cancer. So the first question that was asked by Nelly, we did a different study using TriNet X. TriNet X is a compilation of EPIC data within a particular location. We looked about 12,000 or so patients. We realized that within a 5-year period, patients with atrial fibrillation, no past history of cancer, about 50% of them develop cancer within 90 days.
Wait, that's very interesting. Go back now.
Yeah.
To what extent
So
do
if
you
we look about,
discriminate within that? Yeah, go ahead.
so we realize a lot of the patients who develop cancer, okay, 50% of them developed it within 90 days.
Okay.
Okay. And then when we looked at the 1-year incidence rate of
Uh-huh.
atrial fibrillation to cancer within a 5-year period, the incidence rate was about 25%. Now, when we
Mhm.
compare that with other data that has been shown, that has been, proven the idea of
Right.
atrial fibrillation to cancer is within the same range, between 16 to 30%, depending, which population. Are you looking at the Asian population or other types of population?
So do you discriminate amongst the age groups? Is that what I'm?
And based on race, sorry.
Okay. Okay.
Based on race. So because most of the studies that we've seen are coming from, we have Asian data that we've seen
Okay.
most of those things coming out. So the
Okay.
research typically would differ depending which country it's coming from.
Exactly.
Yeah.
Exactly.
But
Yeah.
the
Yeah. This
range,
is. Go ahead. I'm sorry.
no, no
Uh-huh.
problem. The range is between 16 to 30%. In our own case, we saw about 25% incidence rate.
This is really very, very interesting. One of my PhD students was looking at prostate cancer. This is one of my PhD students at Jackson State,
Mhm.
and in that arena, um, again, depending on race and depending on country or region, uh, very much a big difference. And some of the so there were genetic factors, there were epidemiological factors, there are uh, environmental conditions, but it was amazing uh, the higher incidence of prostate cancer in men, higher in this continent, put it that way,
Right.
compared to, let's say, Southeast Asia and and certain African countries. And that's what I was trying to get at. That's what you're hitting at, right? I mean,
Mhm. Right.
that's what we're getting at.
Right.
So, in this respect, are there recommendations for prevention?
So, that's a good question. That's something we're trying to identify. Okay, is there something that is triggering? Is the cancer hidden that has not been identified, but is triggering AFib, right? Maybe
Yeah,
AFib might be a kind of a sign that there's something else happening, which initially may not be identified. Because usually when you go for a test, number one, AFib is hard to identify.
yeah,
We have this proximal AFib and it's hard to identify usually, but thank goodness we have Fitbits, right? And other types of electronic device that can capture it. But usually by the time you get to the hospital, it probably will disappear.
yeah.
So right now, when they are captured, is there any reason why that is happening? Is it purely cardiovascular or is there any subclinical cancer, something that hasn't been identified? We don't really know. This is an area that is kind of evolving, which is why, to your friend,
Yeah.
yeah. Mhm.
Oh my God, yes, this is absolutely. I'm going back. Um, I was involved for some time with acute lymphoblastic leukemia in children.
Mhm.
At that time, we were looking at how it could be the question was, can it be transmitted from person to person? There was research done with acute lymphoblastic leukemia in cats. In that case, amongst the cats, it was transmitted to kittens. Okay, but I mean, I haven't followed through in the last few years if there is this possibility. I mean, of course, that raised the question about humans. Now, I know, acute lymphoblastic leukemia in children is now almost 100% cured, but those are the kinds of things that do we have any information on anything like that? Is it possible to come up with something on that?
Right.
You know, mitigation of the disease or transmission? Do we know? That's those are some questions, I guess.
Right. Exactly. Agree.
Yeah. This is fascinating work, and I think I'm so pleased that Dr. Feng is, and you all, actually all of you over there at the College of Pharmacy working on this. This is very exciting work. Can we have other questions from or other feedback from anyone working in this area?
Hello.
Yeah,
Hey, Dr. Ano.
Yes,
yes.
Paul, how are
Hi.
you?
Yeah, I'm
Good.
good. Thank you for
Good.
attending.
Well,
Good.
I've listened. It's too technical for me. Of course, you know from my background when you go to all those
Right. Yeah.
that's. But I think on a general level, I want to say very interesting and very useful, especially the importance of cancer research. Just my own just curious, following up with what Dr. Allo asked about, is this specific to, it looks to me, or it seems to me that the cancers you're talking about are those related to like the heart or something, but it doesn't cover other cancers that deal with internal organs like the pancreas and other things. So am I correct to say that this study doesn't cover all aspects of the cancers that people suffer, or, or can it be applied or adapted to other kinds of cancers? Am I making sense at all?
Yeah, Dr. Ano, I know what you mean. Here, in this research, we consider what the patients, and we consider every patients who may have the cancer or not in the future. That means here, for the cancer, uh, we do not consider the difference among the cancers. Even they have the cancers, that the information we were interested. But in the future, in the near future, we can consider a specific cancer to explore whether every patient to have a cancer or not. For example, for the breast cancer or for the non-cancer, only for the specific cancer, we can do the research. Of course, we can do that. Because we have fill all of this, and we have the code. If we only consider one specific type of cancer, it will be very easy for me to do that. For what kind of cancer we have, we can do that very easily. Yeah.
Thank you.
Mhm.
Again, where's your data coming from? I'm sorry.
From the UK Biobank.
Okay. 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 Other questions, please? Anyone? Well, I must say, we really, really want to encourage your work and your colleagues' work at the College of Pharmacy in this whole arena. This is so very important, and I do know that the tools, the deep learning tools will make a very, very big difference here. Are we using any of this information now on being able to develop drugs, the design of a drug to help combat some of this? Is that information? Are you pulling information from what you're learning to develop,
Yeah,
say,
yeah,
a synthetic
yeah,
drug?
and you can see that here, here we have the top seven features. We know the for the medication for B01AA, for the medication for B, and this has a medication for C10AA. Here we have three types of medication can help us to predict whether they have cancer in the future. This is the medication information. And we also have the procedural information. And we also have the diagnostic information. I mean, comorbidity information, whether this comorbidity may have them to have the cancer in the future. I think this information should be very informative to the clinicians or the patients.
Right. So, and just to build on what Tiafeng said, with machine learning, it tried to predict based on pattern.
Right.
And
Correct.
sometimes once it sees certain patterns, we don't really know whether it's positive or negative. Though we can say it's positive, but is it positive because that is a cause or just because it's just a pattern? So why I said this is because as we've noticed this pattern, what we're going to do is we're going to go back and then if we identify, let's say a beta blocker has been shown to improve that, but we're not sure whether it's improving or not. What we can do is to take it back and then hopefully use kind of a propensity score analysis and then compare two groups between drug A to drug B to see if there's any cause and effect associated with that drug. So this is kind of a step towards that kind of analysis.
So this is at the prescriptive part. This is a prescriptive analysis. Is that right?
Uh, this kind of plot can tell us the relative importance of the features in predicting the outcome variable.
Uh-huh.
And we also have another limited plot. This would be very useful. And this information can some kind of to tell us the direction of the features. For
Right.
example, here we know this direction. This shall be very informative to the patients or to the clinicians.
Well, yeah, because the prescriptive part will give you options and tell you
Yeah,
what the potential outcomes of each option could be, right? Is that in
yeah,
that?
yes, yeah. And we also have we also have another plot, and this plot can help us. You can see for this area, this area is the only clinical significance for the features in predicting the outcome variable. For this area, there's only have the statistical significance in predicting the outcome variable. But for this area, there's about 11 features. They both clinical significant and statistical significant. They're very useful information.
Yes. Yeah. Okay. This again, tremendous, amazing work, and strongly encourage you all. I hope we can. I hope our cluster can work more closely with you on this. I see tremendous uh, outcomes here.
Mhm,
You're doing a very, so I really do hope our team, our AI machine learning, deep learning cluster we have could work more. Let's work more together on this. This would be, I think, fantastic. Uh,
mhm,
there's great stuff, great stuff here. Questions from others? We're hitting 4 o'clock. I mean 5 o'clock. 5 o'clock. So uh, I want to thank all of you then for attending. I hope this has motivated additional individuals to get involved in this type of research. I hope this presentation will bring forth additional researchers in this area, and we could all work together on this. This is a very important direction, I think, for us to go. My opinion. So, thank you all very, very much for attending. We really appreciate it. And if you, are we taking a, Erdal, will there be a survey after this? Erdal, are you with us?
I I don't have one prepared. I can make one and send one out.
Yeah, we would love if we could get the feedback from y'all. Erdal, yeah, that would be great if we could send out a survey of this. Okay.
Okay.
Thank you so much, everybody. Have a great evening. Take care. Bye
Thank
now.
you. Thank you for your attendance.
Thank you.
Mhm.